have that broader participation. But it is part of the series that here at the GFF, we've been trying to raise the profile of the care, particularly around the perinatal period, including, as you would remember from a previous webinar, around stillbirth counting and addressing stillbirths. And today we're looking at the care of the low birth weight infant. I think for many of us, you know, over the last 20 years, when I started as an academic at Melbourne University 20 years ago, there was no Lancet series on newborn care. We were, you know, really, there wasn't a lot of attention paid. And we know that, you know, this is you know, we manage what we measure and what we think about. And newborns have been late to the party and late to get the attention that they really should have. We saw that in the MDGs, where in the Millennium Development Goals, the progress we saw was largely in the post-neonatal period. And now neonates make up a much larger proportion of all of under 5 deaths. And I think probably many of us have been in clinics, in settings, in the parts of the world where you're all based, where the newborn corner is a hastily set up, might be a piece of cloth on a table or on another bed. The very emblematic of the fact that we haven't put the focus on this population, and it's to our shame, really. So it's great to see increasing attention on the needs of the newborn. And again, I think that, you know, this has been a maturation progress. We start with essential newborn care, and we're all keen to get all of the basic essential newborn care happening, but we can't reach the Sustainable Development Goals for newborn health without addressing the fact that, you know, 70% of the deaths are in low birth weight babies. And so it's very exciting today to have this research presented by those that have been leading the program in India, in Nigeria, and of course from very good leadership from Dr. Rajiv at WHO. And what I'd like to say, I'm about to hand over back to Sonam to introduce the speakers, but recognize that within this program, there'll be time to ask questions in the chat, so please do that. And then there will be a deeper dive in a few weeks where we can draw all the questions and queries and all of really consider the implications of how you implement some of the findings that come out of this really important research. So I want to warmly welcome you and hand over to Sonam, who will introduce our speakers today. Thanks.
Much, Alison. I'm just looking at the participants, and I'm glad to see a lot of our World Bank colleagues really appreciate joining a session that is focused on MNCH and very service delivery oriented, very perhaps even clinical in some ways. And just want to remind the group that this is it's an opportunity for us to think about the health system overall. And if we can get KMC and immediate KMC right, it means that we're bringing moms and babies together in units. And that's the kind of care that we need at the center of a district health system, for example, to really be able to provide quality care across the spectrum. It's not going to be easy to do. I remember when I was first training, the hospital I trained in was transitioning from passing babies over to the incubator immediately to doing skin to skin, to putting babies onto the chest. I'm talking about full-term babies. And I remember first, two things stand out. One is that when we put babies to the chest, they would stop crying. And it scared people. You know, the nurses, everybody was like, what is wrong with our babies? They're not screaming anymore. But what was happening was that the babies were better regulated. Their heart rates were lower, they were warmer, they were comfortable with their mothers. The other thing that stands out to me is that it was incredibly difficult to make even that small change of taking a healthy full-term baby, not what we're talking about today, and putting that baby directly on mom's chest. It took years to be able to change those small processes, you know, in one hospital. And it stood out to me as an example of the challenges of culture change, of really moving from one way of doing things to another among a group of experts. So I don't think what we're talking about here is easy, but I think there's incredible potential. You'll feel all the details right now from Dr. Rajiv Ball, and I'm really pleased to be able to introduce him. Dr. Ball leads the research team at the Department of Maternal and Newborn, Child and Adolescent Health and Aging at the World Health Organization. He's also the head of the newborn health unit there. He is a pediatrician, also with a PhD in public health, who's been doing research on newborn and child health for over 3 decades at this point. He's been at the WHO now since 2003, but before that was at the All India Institute of Medical Sciences for many years, and has quite an impressive long list of publications behind his name. We're so excited to have him. Let me pass over to Dr. Ball, who will speak for about 15 minutes. And then I will come back and introduce Dr. Tilani and Arya. Thank you very much. Over to you.
Thank you very much, Sanam and Alison, for setting the scene, and again, very excited to see so many colleagues from countries in this webinar. Since I have only 15 minutes, I will jump straight into the topic of today, which is about immediate KMC. But as Sanam was talking about it, there is a huge implication here, which basically means what we are trying to do here. You will see how much of implication it has if we manage to do what we have tried to do in this research study. This research study of immediate kangaroo mother care for survival of small babies or low birth weight babies was conducted in 5 countries, one in South Asia, which is India, and 4 countries in sub-Saharan Africa, Ghana, Nigeria, Malawi, and Tanzania. Today we have with me 2 colleagues, 1 or 2 sets of colleagues from India and Nigeria to share with you some of the actual implementation experiences. The study was also supported by similar work being done in Sweden and Norway. So it's not just a question of low and middle income country issue. So I am only presenting on behalf of this entire team and would be happy to engage with any questions with my colleagues that you may have. So I don't want to delve into too much why preterm and low birth weight is important. All I want to say is that one figure, 70 to 80% of all neonatal deaths occur in preterm or low birth weight babies. So it goes without saying that if you want to reduce mortality in children, you have to reduce neonatal mortality. If you want to reduce neonatal mortality, you have to reduce mortality in preterm and low birth weight children or infants. Current guidelines of KMC, we know that KMC is effective, and the current recommendations are that KMC should be initiated in health facilities in the routine care of newborns weighing 2 kilograms or less at birth, but only brief sessions should be initiated when clinical condition begins to stabilize, and continuous KMC should only be done after the babies are clinically stable. That is what all of us know. Anybody who has been working with newborn health, we wait until the babies begin to stabilize to even start brief sessions and then start KMC after the baby is stable. So why do we have these guidelines? We have this old evidence that about 40% reduction in neonatal mortality, but almost in every single important outcome, sepsis, readmission to hospital, hypothermia, hypoglycemia, exclusive breastfeeding, weight gain, everything is improved by Kangaroo Mother Care. So that was not our research question. Our research question was, does Kangaroo Mother Care, initiated immediately after birth, which we are now calling immediate KMC, compared to the current guidelines, which is starting KMC later, improve survival? And why? Because if you look at the previous evidence, all the studies were done when babies were stabilized, and average 3 days after birth, babies were started on KMC, ranging from one study in Ethiopia, which started relatively early with a median of 10 hours, to 25 days after birth. So what is the problem with that? The problem with that is half of the preterm deaths occur very early in the first 24 hours. And if you take the first 3 days, majority of deaths, at least 2/3 of deaths, would have occurred by the time KMC could even be started. So we set out to look at, if you start KMC early versus KMC late, is there a difference in survival? 2 small studies in Vietnam and South Africa were already published, which showed that skin-to-skin contact starting immediately after birth is safe and helps babies stabilize faster. Something of what Sanam was saying, for even term babies, for preterm babies also, these small studies had found that these babies were stable earlier. We conducted this study, which was a randomized controlled trial, which was multi-country, multi-center. And the population was small babies admitted to the NICUs, or newborn care units, or newborn intensive care units. Most of them were not actually intensive care units. You know what type of newborn care units we have in Africa. Perhaps the India one was actually a NICU, but it was a level 2 NICU. And these were very small babies between 1 kilo and 1.8 kilo. Why 1.8 kilo? Because that was the mandatory weight below which every baby had to be admitted to the NICU or newborn care unit. And why more than 1 kilo? Because many of the sites were not providing high quality care for survival of babies who were below 1 kilo. The intervention, as I have said earlier, was KMC started or initiated soon after birth, as soon as possible after birth, by the mother or by a surrogate, which is somebody that the mother chooses to do KMC on her behalf if she is unable to come to the newborn care unit because of her own health situation, or because the baby had to be immediately moved to the NICU for the baby's condition. Control, very importantly, control is not nothing. Control also received KMC, but it was initiated only after the baby was stable. So this is just showing you that in what we call now, I'll explain that MNICU, which is the mother NICU, the baby starts with continuous KMC as soon as possible after birth. And throughout the stay in MNICU, continuous KMC is provided. And when baby becomes stable, baby is moved out to a KMC ward and continuous KMC is provided. So this group starts with KMC as soon as possible after birth, continues on KMC in the hospital until discharge, and even after going home. In the control group, the baby receives care in a warmer or an incubator in the NICU. And after baby is recovering, brief sessions of KMC have started, but baby is stable, moved to the KMC ward. And that's where KMC in a continuous form is started. Just showing you what the inclusion criteria were, very broad. We included all babies between 1 and 1.8 kgs, even twins and those born of cesarean section. Why? Because we wanted the results to be generalizable. It is more difficult to do KMC for twins and for cesarean section babies, but we still included these. Only exclusions were those which were unable to provide consent, or mothers had so many complications or so were in such a difficult medical condition that they would not be able to provide any skin to skin in the first 3 days of life. We did not include triplets or quadruplets, which were anyways very rare. Babies who were not breathing spontaneously within the first hour, which means they were too sick to even start on KMC, and severe congenital malformations that would interfere with the intervention, or the intervention would interfere with them. Lastly was a logistic issue of a place of residence where a 28-day follow-up was feasible. The three components of the intervention were continuous skin-to-skin care or contact with the mother or the surrogate, starting early, within 2 hours of birth, aiming for continuously more than 20 hours a day. That was the aim. Counseling and support for exclusive breast milk feeding and breastfeeding, and provision of all the required medical care for mothers and babies in skin-to-skin contact without any separation as much as possible. So for this intervention, we first thought we could do it, do it with something which is in between just getting a chair in the NICU, but it's not possible to have 24/7 Kangaroo Mother Care with just a mother's chair in the NICU or even a reclining chair. What we actually needed was to convert the level 2 NICU into a mother NICU. So which means that the mother or the surrogate moved in to the NICU with the baby. So mother's bed is an integral part of this mother NICU. In India and Tanzania, the sites were able to build separate rooms where such NICUs were built. So 12 to 14 beds were put there. You can see on the left, the India NICU, and on the right, Tanzania. Whereas in the other 3 sites, they converted half of the NICU into mother NICU, and the other half remained exactly as it was. So if you see the picture which says Ghana, you can see one room with incubators where babies are kept in incubators. This is the preterm room, and the other preterm room where the babies are kept with their mothers. In Nigeria, you can see these 4 rooms, which were the mother NICU, and on the opposite, unfortunately, you can't see in this picture. I'm sure Abun will give me another picture to put here. That actually had the normal NICU or the usual NICU on the other side. So even respiratory support was provided. You can see this baby in Malawi and a baby in Nigeria getting oxygen, and on the right getting CPAP in KMC position while the mother and the baby were together. The mean duration of KMC that was achieved was 17 hours per day in the MNICU, compared to, on average, only 1.5 hours of KMC in the control group in the MNICU. After they went out of MNICU, both groups received about 20 hours of KMC per day. This is the control. As you might have seen, babies can be in incubators, open warmers, or even in cots. So to tell you a little bit about the trial, again, I'm not going to go into a great level of detail. Happy to answer questions. We started with every baby who was born in these hospitals, and there were 77,000 mothers and 79,850 infants. And then all those who were eligible, except those who had exclusion criteria, were randomized. And then we had, in the end, about 1,600 babies in each group, one that were randomized to IKMC or immediate KMC, and the other half to conventional KMC. This is just the baseline characteristics. I again don't want to spend too much time except saying 2 things. One, that they were similar at baseline between the 2 groups. And secondly, to point out to you that the mean birth weight was about 1.5 kilos. So these were actually quite small babies, as was our inclusion criteria. And the gestational age was around 33 weeks after birth, at the time of birth. Here are the main results that I want you to just focus on. The first result, which is that the neonatal mortality, those born between the time of enrollment and 28 days of deaths that happened between enrollment and 28 days of life, there was a 25% lower mortality risk in the group that received immediate KMC. And you can see the confidence interval of that 25% is 11% to 36% with a p-value of 0.001. We saw a similar benefit in early neonatal mortality, not really early, even early, because only in the first 3 days, but it did not reach statistical significance. The DSMB stopped the trial for this large benefit on overall neonatal mortality before the trial could be even finished. The secondary outcomes that were really different between the two groups were 18% reduction in sepsis and 35% reduction in hypothermia. Other outcomes were not very different, like exclusive breastfeeding, and the rationale for that is that your breastfeeding at 28 days, all the babies received KMC except for the first 2 or 3 days when they were in the NICU. So they were quite similar outcomes between the groups. But when we looked at very early indicators of breastfeeding, like initiation of breast milk feeds within 24 hours, we saw that the group that was given immediate KMC had quite a bit higher initiation. For example, around 58.5% compared to 45% in the control group. Please remember that we were trying to do breastfeeding for both the groups equally, but yet presence of the mother in the NICU improved the chances that the baby was started on breast milk feeding early, put to the breast, which means suckling on the breast early, as well as being on full breast milk within 7 days. Very importantly, if you looked at the causes of death, the biggest difference was actually in sepsis-related mortality. There was a 36% lower sepsis-related mortality, which was statistically significant. A similar reduction in perinatal asphyxia-related mortality, which was not significant, but no effect on preterm birth complications. The other important thing to mention, some people were concerned in the beginning that there may be more sudden deaths in these small babies because they could be smothered, or they would be so close to the mother, etc., and they would be hidden. But as you can see, the sudden deaths were even a bit lower in the intervention group, although this difference is not statistically significant. The MNICU or Mother NICU had all the facilities of a level 2 NICU, including CPAP, monitor, warmer, IV fluids, oxygen, etc. But except one difference, that it also had an adult bed for the mother or the surrogate with adjustable back support. Additionally, because these mothers and surrogates were here, they had areas for hand hygiene. They had a pantry where they could warm their food and eat. They had an area where they could take a shower or a bath, and they had a toilet, and then other measures of infection control were put in place. So we needed a policy to permit mothers and surrogates to be in the NICU 24/7, and the mother NICU had to be created to keep the mother and baby together from birth with zero separation. If we are able to do this, it would revolutionize the way we think about newborn care or newborn intensive care in hospitals, as is currently practiced. And the benefits may go far beyond KMC, which we can discuss later. I want to end by just showing you that there were 3 major conclusions. There is a 25% reduction in neonatal deaths. If we look at it from a numbers needed to treat perspective, if KMC, immediate KMC is provided to 27 babies, it would save 1 life, which translates to 150,000 additional lives saved. globally per year, which is beyond what the impact of KMC when given to stabilized babies. And this would be a paradigm shift in the care of low birth weight babies. I'd stop here. Thank you very much. I hope I have kept to time. I couldn't see my watch, but over to you, Sanam.
Rajiv, thank you so much for your presentation. I'm going to hand it right over to your colleagues. So Professor Chelani, on camera, and Professor Arya. So our colleagues, Professor Chelani and Arya, join us from the Department of Pediatrics at Vardhaman Mahavir Medical College. Professor Chelani is in charge of newborn services there at Safdarjung Hospital in New Delhi. He has an MD in pediatrics from the same hospital and fellowship training at the University of Pennsylvania in Philadelphia as well. Dr. Chelani has been a leader in newborn care, both in India and also globally, has published widely and has really supported the government of India in scaling newborn care across the country. Similarly, Dr. Arya is also a leader in her field in India. She's a national trainer on a variety in a variety of areas, is a national faculty for the National Resuscitation Program, and has also published and led medical and clinical trials in this area. So really pleased to have both of you on with us. And I will pass it over to Professor Chelani.
Yeah, thanks, Sanam. It's really a pleasure and honor to be on this platform. And thanks for the opportunity to present the implementation challenges which we had during the implementation of the IKMC study at Safdarjung Hospital, Delhi, India. During the implementation, we had the issues of the both infrastructure as well as the processes. As Rajiv has mentioned that new infrastructure, that is mother in NICU, was created where mother and baby stays together till discharge. Now this is against the current norm globally and age-old practice that where the baby is kept inside the NICU, sick babies, and mother is kept in the postnatal ward and she visits the newborn unit intermittently. Now, the healthcare providers, for them, it is difficult to explain to them, both doctors and nurses, because of the change in the infrastructure. And for obstetrician also, they have to take the rounds in the NICU. Normal practices, they see these postnatal, they provide the postnatal care in the wards actually. But now they have to come inside the NICU to provide the postnatal care to moms also. Similarly, if we see the processes, initiating KMC right inside the labor room and immediately after birth, and then transporting these babies to NICU was a challenge, and also the concern among the healthcare providers regarding the infection because of the mothers and surrogate presence. So I would request now from here, Dr. Sugandha Arya to take it further and discuss the processes further in detail, how we overcame those challenges. Dr. Sugandha, please.
Thank you, Dr. Chelani. So IKMC implementation challenges actually were right there from initiating KMC in the delivery area. So to meet this challenge, initiation of skin-to-skin contact of mother and the baby on the delivery table was made a norm. However, mothers soon after delivery, we were not able to shift them to mother NICU with these small sick babies. So KMC was initiated and is being initiated with surrogates, and baby was shifted with surrogate to mother NICU. And mothers were also shifted later on to mother NICU as soon as they stabilize, usually within 2 hours of normal deliveries. Before IKMC study began, the babies were transported from delivery area to NICUs either in transport incubators or they were carried in trays. However, in IKMC study, babies were transported in KMC position, and during the transport, their vitals were monitored and even CPAP was provided if indicated in those cases. Now, once mother and baby, they reach mother NICU, both are cared together 24/7, as Dr. Rajiv has mentioned. They were all facilities of level 2 newborn intensive care inside mother NICU, along with facilities for mother to stay by the side of the baby. In mother NICU, the civil infrastructure, equipments, consumables, most of them were supported from hospital budget itself. However, human resource, including nursing staff, support staff, and security staff were recruited separately for MNICU. And since mothers were going to stay with the baby 24/7, so infrastructure like pantry, toilet, bathing room, this was another challenge. All this infrastructure had to be created. And also an area was earmarked for mothers' examinations, since these mothers have just delivered and may need to be examined during their obstetric rounds. A huge challenge which all the sites actually faced was optimizing respiratory support in the initial first few months of study. It was a huge challenge. What used to happen, there was a frequent dislodgement of the interface when the baby and mother moved in KMC position. And to counter this challenge, binder proved very useful to maintain the neck in slightly extended position to maintain the airway. Nasal interface were optimized, proper fixation was achieved, and finally we were able to handle this challenge, and it became a comfortable procedure in the later part of the study. And baby was also monitored for saturation, heart rate to adjust the CPAP settings while being in KMC position and CPAP simultaneously. KMC garment which was used during the study is the same garment which is being used in Karolinska Institute, Sweden. It has two parts, one binder followed by, which is covered by KMC shirt. And these KMC garments have now been made a regular hospital supply as a consumable for study subjects and now for non-study subjects also. A major challenge which we faced at the beginning of the study on the part of policymakers, all the doctors, nurses, they were very concerned with the possible increase in actually neonatal infections due to the presence of mothers inside NICU 24/7. However, we could convince them, as there was already a systematic review, that actually KMC reduces nosocomial infections because of possible protective effect of maternal microbial flora. And as the study progressed, we observed that mothers can be easily trained to follow asepsis routines. And actually during the study, clinical sepsis rate reduced by 18%, as mentioned by Dr. Rajiv in his presentation. A major challenge in mother NICU is postnatal care of mothers, because these mothers have just delivered and need postnatal care. For this purpose, an essential care package was developed in which neonatal nurses were trained to take care of mothers inside MNICU, and obstetric team comes to MNICU to take rounds and to take care of for the medical care of the mothers. Therefore, very important learning from this challenge was that a strong collaboration between pediatrician and obstetricians is a must to make IKMC a success. This kind of care, where baby and mother both are cared together inside MNICU, has been termed as couplet care. The presence of mother inside MNICU 24/7 actually gives opportunity for mother to be a primary caregiver. She changes diapers, she feeds the babies, she even feeds the baby by cup or palade, and she gives prolonged continuous KMC day and night, thus providing a developmentally supportive care to these small sick newborns. As far as mothers' experience is concerned, we found that mothers feel less anxiety and stress inside MNICU because of their presence by the side of the baby all the time, as compared to the mothers in the whose babies are inside NICU and they are separately in the postnatal wards. They are more anxious. And we have also received a positive feedback from the staff also. Staff feels that actually their workload is reduced due to the presence of mother, and she contributes a lot in the care of the baby. So this KMC study experience has given us an evidence that zero separation of small and sick babies from their mothers is feasible, not only efficacious, safe, and acceptable by both mothers as well as healthcare personnel. After completion of this study, MNICU facility has been continued at Safdarjung Hospital. However, once we finished study in January 2020, COVID pandemic set in. So all the measures have been introduced in MNICU to prevent the entry of COVID positive mothers and to prevent the spread of COVID infection inside MNICU. All COVID appropriate behaviors have been put in practice inside MNICU. And with all these measures, this MNICU facility has been running successfully in Safdarjung throughout the ongoing pandemic with 100% occupancy of 12 mothers and many more babies, because many of our mothers have twin babies, so the numbers exceed. Thank you.
Thank you. Thank you very much, Professor Arya. Thank you also for all the images of these committed mothers with their babies on their chests. It's quite impressive to see. Great. I am going to pass it over now to Professor Adejoy. I'm so sorry. I'm sure I mispronounced your name. Hi, it's nice to see your face. So Professor Adejoy is a professor of pediatrics and child health at the Obafemi Awolowo University in Ife, Nigeria. She's a consultant pediatrician, but she has also had quite a long history of leading in the field of pediatrics and neonatal health. She was the head of Department of Pediatrics and the dean of the medical school at Ife. She's been on the board of several organizations on the subject. She's also currently the president of the Nigeria Society of Pediatric Infectious Disease and co-chair of the Nigerian Child Health Technical Working Group. She's supported the WHO and UNICEF, international organizations, in developing guidelines around child and newborn health, and is a global leader in this area with some really interesting work, especially around pediatric HIV. It's such a pleasure to have you. I'm going to pass it over to you now. Thank you, Professor.
Thank you so much. Thank you. Sorry, are you sharing slide, or should I share from my end?
It is your choice. Would you like to share?
Okay, yes, if I can have access to sharing slide. Share slide. Sorry.
No problem. So we'll hear from the professor for about 10 minutes and then move over to question and answer. And please continue. There's some activity in the chat box, which is great. Please post your questions in the chat box as they come up.
Okay.
We can see your slides.
Yeah, thank you very much for the invitation to be on this platform. I want to say that I work at the Obafemi Awolowo University, Ile-Ife, which is about 250 kilometers to Lagos, the commercial nerve of Nigeria. And the study took place at the Obafemi Awolowo University Teaching Hospital Complex, an affiliate of the university where I work. And this is the neonatal ward where the KMC study took place. And so I'm talking about the preparation for the KMC implementation. The first thing was, part of it was to train health workers. Professor Shilani and Dr. Rajiv has mentioned what it took to get the study in place. And training of health workers changing of behavior. It's something that, had to be taken seriously. And that took about 4 weeks, okay, because of the normal practice, for example, not feeding babies until 48 hours because they are too small, we are afraid of neck. We had to change that practice. Also increasing the temperature in the labor ward theater, and then also training of the research staff. We have employed trained nurses and medical officers, and they had to be trained in the WHO minimum care standard and also in the implementation of the IKMC. One of the things that this study did was to also upgrade all the centers where the study was going to take place, because the practices, like for example, in my center and many other centers, we never had an official CPAP machine. What we used to do was an improvised CPAP machine, okay, bubble CPAP. But this time around, WHO supplied the CPAP. And also we had more phototherapy stands, more modern ones that had lead, and they were more effective. And then pulse oximeters appropriate for the newborn. Okay, so you have continuous monitors and also ambulatory. So when you are taking the babies from the labor ward theater, from labor ward transfer, monitor them, because that was very essential. And also there were warmers to keep the rooms where the babies would be left, warm, in case the mother had to step out to the toilet or to eat or something else, and the baby is left in the cot, then the room had to be kept warm. More importantly, we had to also mobilize the community, not just the hospital community, but even the catchment community, because we already have, people have their own beliefs already. We already started KMC in our hospital. So putting baby in front was no longer a news, but putting baby who were very unstable was a problem, particularly even with pediatricians and obstetricians and nurses. You thought these babies were so small and you're going to tie them in the front of somebody, it looks like this wouldn't work. But luckily, everybody, before the end of the study, was convinced because they saw it work and there was no adverse event in any way. And also the benefit of doing that, we also had to convince them, benefits of bringing in a surrogate, into the theater, into the NICU, into the NICU, where usually was a sacred ground. Nobody was allowed to come in, and also the hospital community and the leadership of the hospital. We needed to do an advocacy because we're going to change some things, like having the NICU inside the NICU. The nurses in the neonatal ward were not used to having mothers, taking care of mothers. And the obstetricians were not used to having to come to do rounds in the neonatal ward. Those were areas that we had to address. And having addressed that, it made it easy to go on. And this is just a preparation, the training of health workers. Okay, these are health workers who are already in the facility. And then the one on the right, my right, is training of research assistants, So we had to do demonstration of what we expect that they will see and what their role will also be. So everybody was confident of this. And then in the training of the WHO minimal package, what were the things we considered? Thermoregulation, okay? Because part of the problem is, like I said, when babies are resuscitated, okay, is the room warm enough? Okay, maintaining that thermoregulation was so important. We had to do it over and over again until everybody got used to doing it. Okay, and then resuscitation. We went over the essential newborn course, for all the people who were working in both labor ward theater, newborn ward, obstetricians, doctors, and midwives. We had to go through all that. And then respiratory care, which was a new area for most of us. Use of CPAP was new. So we had to, and then the monitors, how to regulate it and what we expect to see, the FiO2s, at what level, we went through that over and over again. And then maintaining infection control, even with many people coming in, relations coming in, mothers coming in, we needed to make sure that all the people that were coming in also understood that they had to wash their hands and that there was facility to wash hands, all the time for both mothers and also for other surrogates and other caretakers. Like Sugana had said earlier on, this made mothers become, they become the primary caretaker of their own baby. Okay, and that was something that was a novel. That was something that was a big change for everybody. Prior to this, mothers were not even allowed to come into the NICU. Many mothers who had cesarean section did not see their babies until maybe the 3rd or 4th day, particularly when they're small babies. But this change, you know, there was a big change, and mothers could come in even within hours, you know, to see their babies or stay with their babies. And then also, like I said earlier on about feeding babies, you know, routinely in the past, all babies had to be on IV fluid, all preterm babies had to be on IV fluid, but that had to change because we were able to go through the feeding and expression of breast milk. Even in the 28-weeker, the mothers were able to produce breast milk adequate enough to feed them, knowing that their stomach capacity is also very small at this level. And there was no risk we didn't have any case of necrotic enterocolitis, you know, at least not excessive cases, if you can, you know. And that was something that everybody was happy about, but we had to continually teach how much to give, when to give, you know, and then also the minimal package for the mothers. I think the India team had discussed that extensively. I will not go into that again. Okay, so the other aspect of the training was on the implementation of the immediate Kangaroo Mother Care itself, immediate skin-to-skin contact, how to put the baby in that position. So Ganda went ahead to explain to us how the baby's neck is slightly extended so that the baby does not, you know, so that there's no problem with apnea. Okay, once they are properly tied in with the binder, that was excellent. You had to learn how to do it. And once you know how to do it, it was no problem. Even mothers could do it themselves. So, and then safe transfer of the mother from labor ward and labor ward theater. Usually, if the mother was not available because she has cesarean section or they were still doing some things on her, then the surrogate will have to do this. And she will sit on the wheelchair like was demonstrated to you. And then she will be wheeled into the neonatal ward and taken over by the nurses in the newborn ward, you know, with a vital sign, with vital signs of the baby checked, you know, and then the baby is then transferred onto the surrogate and the baby are then transferred together either onto the chair or onto the bed that is already in the MNICU. The other thing was also to continuous provision of skin-to-skin contact in unstable babies in the first 72 hours when they are in the MNICU. That was an area that we had to let people understand. Many people thought if you want to do any procedure on the baby, you had to bring the baby out. You know, you could take blood from the baby while the baby was in the mother's, on the mother's chest or the surrogate's chest. You could also do your blood glucose monitoring. And that was a lot of things, you know, a lot of change for many people, health workers particularly. And of course, all babies who were stable, okay, they were then moved to the stable KMC room and they had the same effect like they did before beside the study. And then support for breastfeeding, early expression was an important part. I would like to say that part of these things were put in place because we also had different people to play different roles. We have what we call the KMC support staff. Their own area was just to support that these babies were properly placed and that the expression of breast milk was going on as when due. And we also had those who were involved in monitoring the babies, who were taking the vital signs as at when due and using safe techniques. So I think I've mentioned this, okay? We had to convert the seminar room that was attached to our newborn ward even to a stable KMC ward, okay? Because we wanted it to be just, you know, just a door apart. And you just walk down the newborn ward into the stable KMC ward so that you could easily go in to see what is happening there. And this needed the permission of the authority, and which they readily gave. And also, in this same stable KMC ward, we needed to have a resuscitation corner in case any child aspirates or needed to be resuscitated. So you need a resuscitator, you needed a CPAP machine, you need an ambu bag, you need a suctioning machine. And the room had to be kept warm as well. And the mothers had to be kept busy, okay? Of course, you know, African magic is one thing that many mothers enjoy in Africa. So the TV was on and they could watch this. And some of them were even taught how to do small things like knitting caps and also knitting cardigans for their babies while they were in the facility. So in the MNICU, which the picture you are seeing, we had all the things that Rajiv has shown earlier on. You have to have the water thermometer, so you continue to monitor the temperature of the room. You have to have a warmer there, like I said earlier on. Paraventure, the mother wants to step out. You put the baby in the cot, and the room had to be kept warm. Phototherapy stand in case baby needed phototherapy. Particularly in Nigeria, about 40% of our male children tend to have neonatal jaundice, particularly the smaller ones. So jaundice was a problem. Okay, so we needed to have a phototherapy stand there, a CPAP machine, a pulse oximeter that is continuous and is already mounted on the wall, and also a reclining chair for the mother in case she wants to sit up. These mothers could also move around with their babies in their chest, and once the baby is off the CPAP, they could move around the ward, see other mothers too. And also the bed was adjustable headrest. And this is a picture.
Professor Ebun, sorry to interrupt. We have 1 minute left before we need to go to Q&A.
So this is a transfer from labor ward theater, okay? And the other one is the grandmother who is a surrogate, because the mother is still in the theater, okay? And you have seen these pictures before. So this is a follow-up visit as well. We had to make sure that we follow up the babies, okay, as at the protocol. Thank you very much. Thank you. I'd like to stop here.
Thank you, and sorry to rush you. Thanks so much. Allison, let me hand it back to you to close up our session. Thank you so much to our speakers.
Yes, I want to add my thanks to those of Sonam. Really clear presentation, and I really loved the fact that we could hear the implementation challenges, because I think from the perspective of the World Bank and the Global Financing Facility, it's looking at the health system implications of the interventions that are going to really transform outcomes for mothers and newborns. That is what taxes us in our work. So really appreciate that detailed clarity around the infrastructure needs, the heating needs, the staffing needs, and a lot of the behavioural changes that are required. I've really appreciated Raju has been responding to all of the questions in the chat, so please do look at that. We have about 4 minutes for questions. So if anybody has a burning question that hasn't been answered in the chat, please feel free to raise your hand, which you can find under the reactions button at the bottom of your tab, or continue to put the questions in. We are recording all of the questions, and we've obviously recorded this session. And in a couple of weeks' time, we want to have another session where we really dig down into what this actually means for health system redesign. We need to think about how we plan our labour wards, how we plan our neonatal intensive care units to ensure that that M is put in there. And, if you think about the Every Newborn Action Plan, and the trick is in the name of every newborn, one of those indicators is around ensuring that there are facilities in 80% of our subnational administrative units that can manage the care of a small and sick newborn. And if this is an initiative that people are going to start paying attention to, now is the time to reflect on, well, perhaps it's not just a NICU, but we need to ensure that we can keep that couplet care going with the mother and the newborn. Now I'm just checking for any hands up. Don't have any hands up. I might just then finish up here. Please do continue to put any chat. Oh, thanks, Mickey. Noticed that, yeah, a lot of these investments are required for all care as well. You're spot on. I think that this has been an overlooked population, and clearly the importance of addressing, this low birth weight population has been overlooked, and now's the chance to really use this research and others to ensure that that care is provided at an effective level. I want to thank all of our presenters again. Thank you all for joining, and we will be in touch over the next week or so to pass on details for where you can find this recording of this session, and for the invitation for the next workshop on the implications of this. Pascal, did you want to provide any other closing comments?
No, thank you very much, everyone. I just want to add that the next session is on November 2nd.
We lost him.
We look forward to meeting you. And if you have any questions, I'm more than happy to take all this into consideration. Thank you so much. Have a nice afternoon. Merci.
Thank you. Bye.
Thank you, everyone. Thank you so much.
Many thanks
to our speakers. Join us on November 2nd.
Okay, great. I think Alison looked frozen. Merci beaucoup. Thank you so much, everybody. It was a pleasure to meet you, talk to you very soon.
Merci.
Thank you.
Thank you. Have a good day and evening.
Bye. Thank you.
And thank you to our speakers. It was great. It was really, really interesting. Thank you, Dr. Arya. Thank you, Dr. Chelani. Thank you, Ebud, if you allow me.
Merci.
Bye.
Donc,
à très bientôt. Thank you very much. Bye, everyone. Merci pour les interprètes.
Au revoir, merci.
Au revoir.
Merci.
Merci, Asina. À bientôt. Pablo.
Au revoir, merci.